everyone to please silence your cell phones. I'll get into some housekeeping details in a moment, but I want to welcome everybody on behalf of the staff and board of the Rehoboth Community Center. I want to welcome everyone who is here and on Facebook Live to tonight's town hall addressing the hMPVX, or commonly referred to as monkeypox public health emergency. My name is Wes Combs. I'm the board president of Camp Rehoboth, and we are very pleased to be partnering with the Department of Health and Social Services, where we'll be discussing Delaware's response to the virus tonight, as well as allowing you to field questions and concerns from community members, and also hear from a leading doctor who is on the front lines about the science of this. Those panelists include, I'll introduce them in more detail in a moment. We have to my left, Secretary Molly Magarik, who is the Secretary of Health and Social Services of the state of Delaware, and Dr. Marci Drees, the Chief Infection Prevention Officer and Hospital Epidemiologist for ChrisitanaCare. I'll provide a more formal introduction in a moment. Camp Rehoboth, which stands for Create a More Positive Rehoboth, is the largest and oldest organization of its type, serving the needs of the LGBTQ people in the state of Delaware. For more than 32 years, Camp Rehoboth has been dedicated to building a positive and safe community inclusive of all sexual orientations and gender identities in greater Sussex County and actually throughout the state of Delaware. As many of you know, Camp Rehoboth's core mission includes promoting health and wellness in the community, and we are proud to partner with DHSS on this issue. In fact, Camp Rehoboth has been partnering with DHSS for close to a decade, providing HIV education, confidential testing, and free condom distribution throughout Sussex County. Like with HIV, Camp Rehoboth is committed to keeping our communities safe by stopping the spread of this virus, as it is disproportionately impacting men who have sex with men. We've been providing the latest information about the virus as it becomes available from the state, and how those who are in high-risk categories can be connected to services offered by the state, including having received a vaccination. In fact, just this morning, DHSS announced that Camp Rehoboth, as well as AIDS Delaware, have been designated as additional sites to deliver monkeypox vaccinations, and each organization received 200 doses. We sent out an email to all of our members as soon as we were notified of this very important and exciting opportunity, and I am happy to say that we have filled all 200 slots by the end of the day. We didn't even have a chance to send out the questions. I want to make a high thanks to our amazing staff at Camp Rehoboth. We have Lisa Evans as the director, and we have Amber Lee, who is leading our HIV outreach program, who really got the rest of the staff working together. Maddie Brown, our operations administrator, and our development manager, Lori Thompson, and Derek, also, we're on the phones immediately, we're on the phones all day long, entering the information, making sure that we have the information so that we can keep track of it. It's a 2-dose regimen, and the individuals up here will provide that information. I will say that if you are and would like to sign up for a vaccination, I will reach out to AIDS Delaware, and if you provide information, they may have available slots that's up and going to give you information. So now I want to get to people that we're really here to see. A couple of housekeeping items. Restrooms. They are immediately behind me, accessible from either side of this program, so please feel free to use the restroom as you may need. Panelists will be speaking first, and each of them, and then afterward, we'll take questions from the audience, as well as try to take as many questions from Facebook Live. We have asked the panelists for an individual in the room to have them repeat your question, as you will not be on a microphone, so everyone knows what the question is. And we also ask that you only share information about your own personal health situation and not share information about a family member or a friend, because that is a violation of HIPAA and for privacy reasons. So if you're speaking about it, you only speak about your own personal health situation, you're not going to make individual. So without further ado, I'd like to first introduce information on Molly Magarik, is the Cabinet Secretary for DHSS DHSS, a role she assumed in July 2020. Previously, Secretary Molly, as they call her, worked as the Deputy Cabinet Secretary since 2017 as the DHSS Secretary. As the DHSS Secretary, Magarik is the second in command for Delaware's second largest agency, behind only the Department of Education. Magarik's role as DHSS Cabinet Secretary came during the height of the COVID-19 pandemic and will provide more information about Delaware's response to the monkeypox virus. Addressing the medical issues surrounding the virus is Dr. Marci Drees. Dr. Drees is the Chief Infection Prevention Officer and Hospital Epidemiologist for ChrisitanaCare and is a highly sought-after national expert on infectious diseases, healthcare-associated infections, and vaccines. Among her numerous affiliations, Dr. Drees chairs the Education Committee of the Society for Healthcare Epidemiology in America and serves as that organization's liaison to the CDC's Advisory Committee on Immunization Practices. She is board certified in internal medicine and infectious diseases. Before we begin, I'd also like to recognize two special guests who are in the audience. We have Secretary Representative Pete Schwartzbach, Speaker of the House, is here in the room. Support of Camp Rehoboth and for this community over the years. And we also have Rehoboth City Commissioner Edward Shanusky, who has also been a very avid advocate for Camp Rehoboth and all aspects of our community. So without further ado, I turn it over to you.
Thank you so much. Thank you all for being here tonight, and welcome to everyone who's watching on Facebook Live. This is a really important opportunity to be here and have a conversation. I want to try to keep my remarks as brief as possible because I think a lot of the answers to things are a lot of the information will come through answers to questions. And really, I felt like the importance of being here was to hear directly from you all. The frustrations, what you're seeing on the ground, what we need to be doing better. And so I don't want to take up time giving all of the individual details of every little nuance because again, it's a conversation. And one of the pieces that we learned, you all know so well, and that we really learned and was brought into stark relief during the COVID-19 pandemic is you have to go to the impacted communities directly. We at DHSS and the Division of Public Health to sit where we are in Dover or Newcastle and say, here's what the situation is, here's what's going on in the community, that is not going to be an effective public health response. So again, it is very important to come down here tonight and hear directly from you all, see the questions on Facebook, and see what we can be doing better. I will say better that we had it this week than last week. There have been some really important developments over the last week. The most important of which was the FDA, the Food and Drug Administration, using emergency use authorization to change the dosing of the way that the vaccine is delivered, which has enabled us, as opposed to getting 1 dose per vial, to now get 5. So we know that there is intense frustration amongst people who are at highest risk, wanting to get vaccinated, wanting to protect themselves, wanting to know that members of their community can be protected. And again, with this shift, we quintupled the vaccine supply that we have, and we were able to start expanding access. So where were we before? Prior to this week, we were only vaccinating or able to vaccinate people who were determined to be a close contact of someone who tested positive for monkeypox. What we're seeing is that for every initial case or index case, there's about 5 close contacts associated with it. And with only receiving about enough to do about 500 doses, it's a 2-dose series, we only had the ability to vaccinate 250 people prior to, again, this change that the FDA ushered in last week. So now, again, with the ability to essentially quintuple our supply, this week we started, and again, kudos to all of you, as well as people like Dr. Drees, who are doing the work in HIV/AIDS clinics across the state and in community-based organizations. We were able to start vaccinating people who are HIV positive or who are taking the pre-exposure prophylaxis because they are at very high risk of contracting HIV. And the reason for this is one of the groups, those who are HIV positive, who are at the highest risk of severe outcomes from monkeypox. Thankfully, in Delaware, we have not had any hospitalizations from monkeypox, and even more thankful, we have not had any deaths associated with monkeypox. We've had 11 positive cases to date, although we know that that number is probably, it's underestimated both because of testing and the way that the CDC looks at the cases and they are tallied. It is the state of residence. So again, as you all know better than anybody, people make Rehoboth their summer destination. So there are cases that were showing up in the counts in other states that people were infected here in Delaware. So again, we know that 11 is not the true picture of the prevalence of monkeypox in the community or the number of people who again have tested positive due to being in Delaware and activities in Delaware. We are, again, as frustrated as you with the pace of the vaccine supply. Unfortunately or unfortunately, the CDC is prioritizing and distributing vaccine based on positive cases attributed to the state. So they're not looking at the Pennsylvanian who was in Delaware and that's where they contracted it. They're saying Delaware, prior to a few days ago, we were only in the single digits. And so we are in a very vaccine constrained environment at the federal level. There's only one vaccine supplier where we're really seeing, Dr. Drees can get into, the Jynneos is the one that we're using that has less contraindications, or it's able to be used for more people. So that's the vaccine that the federal government is really prioritizing, but it is very constrained. So due to the fact that, again, we only have had 11 cases that are attributed to Delaware, it has been very difficult to get the necessary supply and to meet the intense demand and desire of people to protect themselves as well as their community and family members. So we share your frustration. Obviously, I don't want to put myself in the shoes of people who have residual trauma from the HIV/AIDS pandemic and the government response to that. But I can imagine, again, the frustration based on the frustration we have. So we very much welcome the FDA's response, but we know, again, if 200 vaccine appointments filled in about 6 hours, we could have probably filled 1,000. And by we, I mean the wonderful people at Camp Rehoboth could have filled 1,000 spots. So we know we have more work to do. We are reaching out, and other community partners like Camp Rehoboth are reaching out to the federal delegation, pleading to please increase the vaccine supply and acknowledge that, again, if there's interest and we're filling vaccination spots this quickly, there is so much more demand. And don't we want to we already feel like we're behind with vaccines. We have an opportunity to catch up and really, again, protect people. So with that, again, I don't want to take up all the time with my comments. Dr. Drees is an expert. I want to turn it over to her, but I very much look forward to your feedback and questions, including critical ones, or, hey, Delaware, you need to do better. We welcome any and all of that feedback. It's very important for us to have, again, a robust response. It must be partnerships with community and not something where the state is individually taking it on. And one more thing, because I want to acknowledge Dr. Drees and ChrisitanaCare. I know we're here to talk about monkeypox, but they were so, Dr. Drees herself as well as ChrisitanaCare were just so invaluable in the COVID-19 response, coming down here, doing testing clinics, in poultry sites and in communities that were underrepresented, where there were language barriers, really just getting into the streets and doing real true grassroots public health as well as community-based health. So Dr. Drees, thank you so much for everything that you have done and that you continue to do.
Thank you so much, Secretary Magarik. And thank you to all of you for being here and online and for the invitation to speak. I'll keep my comments also relatively brief. I just want to give kind of a brief summary of what we know about monkeypox right now. Monkeypox is not a new virus. It was first discovered in the 1950s in animals, and in the 1970s, human infections were identified. And it has had a low level of transmission kind of ever since then, mostly in Central and Western Africa. And the cases that we would see were typically travel-related. There was a small outbreak, relatively small outbreak in 2003 related to imported prairie dogs or imported rodents. But this, obviously, what we're seeing now is definitely new in terms of how it is spreading consistently person to person. What was described in the past was, a person would get monkeypox from an animal, maybe pass on to, 2, 3, 4 other people, but then the chain of transmission would stop. And obviously that's not what we're seeing now. We're seeing sustained transmission among people. It is a disease very similar to smallpox, which many people don't remember, thankfully. It's been eradicated, but it is milder. But it has otherwise a very similar clinical course with a very similar looking rash. The way that monkeypox is transmitted is really through close personal contact, typically skin to skin, but also can be respiratory if you're really face to face with somebody for a prolonged period of time, kissing, snuggling, whatever. That is a way to spread it. It can also be transmitted through contact with clothing or bedding that someone with monkeypox has contaminated. And then mothers can pass it on in utero to their babies. And you can also, again, still transmit or acquire it from animals, although that part's not been spread in the United States. The clinical signs and symptoms, again, classic monkeypox was very well described as you start with what's called a prodrome, very non-specific. You might have a fever or a headache, body aches, feels like the flu, feels like COVID, could be anything. And then within a few days, you would start to get a rash that would start, usually in one part of the body and spread throughout the entire body. And that rash had a very clear progression from, small pimple-like lesions to larger painful lesions. They would eventually scab over, and it was always a very clear progression. We're seeing a little bit of different presentations in this outbreak. We're seeing people that don't have that prodrome, they just start with the rash, or the prodrome starts at the same time as the rash. We see people that are presenting with what looks like a sexually transmitted infection. So it might look like syphilis, it might look like gonorrhea or chlamydia. It might start with rectal pain, with not any clear rash, but often when you go looking for it, a rash can be found. You can get lesions inside the mouth, inside the rectum, as well as on the skin. And some of these rashes are staying in the genital area, some of them are more widespread throughout the body. Once the rash occurs, it can take actually 2 to 3 weeks, sometimes even as long as 4 weeks, for all the lesions to make it through to the point where you're not contagious. So it is a pretty significant, even if you don't end up in the hospital, it can be painful, and you can end up having to isolate for a significant amount of time to prevent spread to others. The good thing is, because this is not a brand new disease, people have been working on it for a long time. We do have a few tools already in our toolbox. It wasn't like COVID where we had to kind of come up with a vaccine, and it took a year, which was miraculous that we got it back quickly, but it still took a year. So there is, the Jynneos vaccine that was mentioned is the one that we're primarily using because it doesn't have the side effects that the older smallpox vaccine did. But it is in limited supply. It is FDA approved for monkeypox, so it's been studied, gone through the typical FDA process. It is a 2-dose series, roughly 28 days apart. What's not known about this vaccine is exactly how effective it is. So we know it's not 100% effective, but we don't know, is it 90%, 85%? It hasn't been studied in such a way that we can really give a definitive number about how effective it is. So it's really important, as people are getting vaccinated, that they still do all the other things that they can do, whatever else they can do to limit their exposure. We know that 1 dose is certainly not sufficient protection, so you really do need that second dose. And you're not considered maximally protected until 2 weeks after that second dose. So in the meantime, we're asking people to, temporarily cut back on ways that you could get exposed. Again, that skin-to-skin contact with other people that may have monkeypox. The good thing about that is we think that most people who have monkeypox are showing symptoms. Although they may be mild, they may not realize. So again, it's having that conversation with your partners before having any significant contact to see if either of you have any symptoms, and certainly not pursuing if either of you potentially have symptoms that could be The other thing that we do have in the toolbox is treatment. So there is an antiviral drug that's FDA approved for smallpox, but felt to have probable activity against monkeypox as well. It's called tecovirimat for TPOX. And I should say not everybody who gets monkeypox needs to be treated. For the most part, the illness is self-limited. It will get better on its own in 3 to 4 weeks at most. But we are recommending treatment for people who have severe disease, or if the location of the lesions is problematic, if there's a lot of lesions on the face that could create scarring, that might be a person that's recommended to have treatment. It is similar to the vaccine issues. It is difficult to get TPOX. There's a process that you have to go through to get drug for each individual patient that's recommended. So we're still kind of ironing out all the last details at Christiana to operationalize that, but I think we're pretty close. And again, the majority of people probably won't need it, but we do want to have that available for people that might need it. And with that, we'll open up for questions.
So people could, who has a question, you can raise your hand. It's a question. Okay, I'll take this question first. You can just stand up and say your first name or name and ask what the question is for Helen.
Thanks, Wes. My name is Gary Tillman. The question is in the context of knowing that we really don't have an adequate supply of vaccine or treatments to TPOX, what we can do on the prevention side. And the question goes to how are we using our existing networks built around HIV prevention, testing, education. How can we incorporate a prevention message and real guidance to people who come in for HIV testing around the issue of monkeypox? We have very, thank you, we have a very active HIV testing and prevention program in the state, and it seems like we've already got a built infrastructure. How can we expand it? I'm on the state HIV Advisory Council, and I think we have not only at Christiana, but we have other testing sites and mobile sites around the state. How can we use those effectively with a prevention message that's on mark, on target, understanding it's more complex than HIV? Sorry, that was so wordy.
So what do you do to sort of summarize that question? Well, I think what I heard the question is, how can Delaware take advantage of the infrastructure that was developed in response to the HIV/AIDS epidemic? And in addition to that, how can we expand upon it to even increase the prevention message as this virus continues to be a problem in our community?
Thank you, Wes.
Yeah, I mean, I think, it's events like these, it's obviously working with our community partners, because you guys are aware of the people that need to know this information are. We can put everything we want to on the website, and, CDC has tons of stuff on their website, and there's a lot of great information there, but unless you're actively going to look for it, it's not going to make it better. So I think we need to do, events like these and more to get the message out to people that need to hear.
And I'll just add, like we did with the coronavirus, there is a state website, so de.gov/monkeypox. Again, as Dr. Drees said, there are ways to customize that information and we need to have the conversations with communities to say what information really is the most relevant, and is there an infographic, or what can we do to really distill down the most important information that we want specific communities to take away. And again, as was mentioned, we absolutely are. The Division of Public Health and the team at Public Health already has relationships, so we are not reinventing the wheel. We do not want to reinvent the wheel. But we do want to make sure that we have the ability of people to get information who are new and say, I don't know where to go. It's hard to believe that people haven't heard of Rehoboth or AIDS Delaware or some others, but we know that there are communities and there are individuals, so we always have to be looking at our response and be willing to hear feedback that it's not robust or we missed the mark. despite people trying really hard and people very passionate, as Dr. Drees said, it is conversations like these that really enable us to understand how we really are the most effective and how we have this partner and community-based response, especially when we have populations that are so overrepresented in the numbers, like we're seeing with monkeypox. We have to have continued conversations with this community.
We're HIV testing counselors throughout the state need guidance to augment what we're doing already. Thank you.
Wonderful, thank you. That comment was we have HIV counselors throughout the state. They need to be given direct information about monkeypox so that they can be having conversations with the people who they are currently serving.
And just want to ask Amber, what was going on to follow up on that our HIV response? Is there any information? How is Camp Rehoboth?
We've actually received a lot of phone calls as monkeypox has been developing, and we have always either referred to the website or went to the CDC, and literally I have read what's on the website. We work very close with CPH, and Brianna is actually here, so she's one of our advisors from there, and we just monitor that and make sure we're using the right information and that we're giving that out.
Thank you.
Hi, Tim Langen. I'm actually an internist. My training used to work at ChrisitanaCare. I do hospice. And Secretary Magarik, I thank you for being here, but I do have to give some serious criticism. I started contacting DHSS through Jill Friedan a month and a half ago, saying you guys need to pull together a plan. If you've looked at any of the other towns up and down the East Coast, Algonquin, Maine, Provincetown, Asbury Park, even if they didn't have vaccines, they had something set up to get people registered. This came out today, and look what happened. Everyone signed up. It's really, Dr. Hong, in Jill's emails, and I would be glad to share these with you. Dr. Hong saw no need for a mass vaccination clinic. This was 3 weeks ago. And all of a sudden now it's come about. And I understand, like, if you had no vaccines, you had no vaccines. But you could have set up a list, you could have set something. That's what they were doing everywhere else. And I just really feel like the leadership was not there. I'm sorry, like, I don't know how much you were involved with this, but Dr. Hong really has not led on this. And it's really worrisome to people in our community. You know, if you go out to Diego's, which is the dance club you come in, you know, even if you're not, you know, sexually active with someone else, people are dancing, church off, you go all around town. And I was saying this to people at DHSS, and they weren't responding. They said, at this time, there's no point. So I just, you know, take some sense on this, please. And I appreciate that you're accepting their criticism because I've been after them for the past almost month and a half. And it seems like it wasn't a problem. And for anyone who has lived through HIV in the past, like you said, you know, people in this room have probably lost friends. And it was starting to feel like that, and that was probably before my time, but I can understand how people felt then. So.
Yeah, absolutely. Well, I mean, as public health is member of DHSS, so obviously I do have to take responsibility regardless of what the individual response. And so, really, and this is part of taking criticism is not making excuses, but I do think it's really important to say that the team at public health, first of all, we do have an interim director, Dr. Hong, who was previously the medical director. This is a team that really has been battered by COVID and is very threadbare, for lack of a better term. And so again, that's not to make excuses, but we are having conversations, and there's a lot of state health officers like Dr. Hong who are pushing the federal government. We need reinforcements. We are still under something called the State Health Operations Center. We are still at shock level 2 for COVID. We're seeing some of the highest test positivity rates. We still have that infrastructure running. And now, obviously, we have to be focused on monkeypox. And we are at shock level 1 for monkeypox based on the number of cases, the lack of hospitalizations, and thank God, again, the lack of deaths. So there's always room for improvement. But I'd be remiss if I didn't say I am concerned if this does get worse and we are not able to get more vaccine or an easier pathway to getting the antivirals. we do not have the same infrastructure to set up mass vaccination pods. And so we need to rely, we always need to rely on community partners, we need to rely on our health system partners. If the expectation is that the state of Delaware, via public health or other people at our department, is really the sole response to this, we're not going to meet the challenge because we're approaching an almost 35% vacancy rate. And we are barely hanging on, and that's not feel sorry for us, and again, it's not to make excuses, it's to be very real about the challenges we had, and so many people at Division of Public Health have hung in there with us over the last 3 years, hoping that the end was in sight, and now we have monkeypox, so we are, again, going to keep taking the criticism, and I take it as it's important. We need to hear it, and we need to do everything we can, and we need to be honest where there are limitations to our response, and where we need, again, wonderful partners like ChrisitanaCare, BD, Dr. Chasanoff did a town hall last night, BD's doing wonderful work. We really need all of it. So again, thank you so much. I appreciate you being in Trumpet. I'm sorry it's been so difficult to get a response. But happy to give my personal, and again, I don't want this to fall on the Division of Public Health. It's on me, and it's really on, again, our friends at the federal level. We need more funding so that we can really staff up and give this infectious disease the response we think it needs based on the trajectory of cases.
Do you have another question?
My name is T.D. Steiner. Could you speak to the FDA's change where they've been split doses and the effectiveness and whether it's followed up with full dose together, or how does that work?
Yeah, so the question is about the FDA's decision to grant an emergency use authorization for the intradermal vaccine. So the idea here is that you have a ton of immune cells in your skin. And this way of administering vaccines has been studied not just with monkeypox vaccine, but with flu, with other vaccines as well. And you can get away with a much smaller dose just because of the density of immune cells that are in your skin. And so the decision to grant that emergency use authorization was based on one very small study from 2015, but they really showed that the antibody levels after a subcutaneous dose, which is the traditional route, or the intradermal dose, were basically, you could not see 2 lines apart. They were almost identical. So I think the FDA and other leaders are very confident that even though it was a small study, the lines were so close that having multiple bigger studies were probably not going to show a different result. And so, there is this emergency need, right, to really expand the availability of this vaccine to the communities that need it. So they thought that risk was worth taking.
Do you know anything about the manufacturers as they are not, they were what's on the list
So the question is about the manufacturer had some publicity around this variant. I don't know specifically what they said. I think, our natural instinct is to, this is the way the vaccine was truly studied, so we should try to follow that as much as possible. So I think there might be some, there is some risk there because it wasn't approved originally as an intradermal dose. But again, I think you have to balance the risks with the potential benefit of, quintupling the amount of vaccine that's available. So I think, having read the data that I've seen, I'm pretty comfortable moving in that direction. I do think, it's still very imperative that both doses be given at the same 28-day interval, but I don't think the method of vaccination is quite as critical.
There's a question from Facebook Live from Mark Lefura. To the new secretary. Why hasn't Delaware declared monkeypox a public health emergency like the federal government and the World Health Organization? Will you do that tonight right now?
Sure. So this is a really good question, and I think again it's really important, and it was something that I wanted to bring up if nobody asked, so that we could clarify, because I can again completely appreciate how, given the challenges that people have had, this looks like another sign that Delaware doesn't care, and that Delaware is not taking this seriously. When we've looked at the requirements under state law to declare something a public health emergency, the lack, and again, these are things to be grateful for, so I don't need to cast them in a negative light, but the fact that when we stand at 11 cases. We have not had any hospitalizations or threat to the larger healthcare system the way we saw with COVID, and the fact that we have not had deaths. Monkeypox right now just does not meet the criteria to be declared a public health emergency. That being said, we do have a lot of flexibilities. The fact that we can deploy SHOC, we don't need a public health emergency to raise the level of the State Health Operations Center. We're having briefings, just talked to the governor again yesterday. So we believe that at this point, especially looking at what the federal government has allowed and the changes to the vaccination dosage, and the fact that we are still in a pandemic response posture because of COVID, that we have the flexibility to deploy our team and to be able to respond to this with the tools that we have available to us. But again, it's a great question, and I completely understand why there is concern and a desire that we declare something tonight. Unfortunately, I cannot. But again, hopefully being here and the changes in the work that we're doing, we will start to show you that we are taking this very seriously. And as much as I would love for it to be a public health emergency, because I think that's consistent with the level of concern and what we're seeing, I'm also grateful that we have not had the level of cases, because even as Dr. Drees said, the fact that people don't die from this, it's still incredibly painful. It's also very isolating. If you are waiting until scabs crust over and fall off and then new skin underneath, that can be a multi-week process during a time when people are isolating, possibly alone. So we have mental health concerns about people and what resources they have available. So if I could just mention those, we continue to have, through the Delaware Psychological Association, there are 6 free counseling sessions that are available to people regardless of insurer status. If you just go to Google DE Psychological Association or look on the Division of Substance Abuse and Mental Health's website, you can see information on that. We have the Delaware Hope Line that's available 24/7 if people want to have a conversation and are feeling, whatever they are feeling about this, whether that's despair or frustration, anger, etc. Again, that's available to people. We also have our bridge clinics. I would say if you are isolating and have tested positive, please wait to go to those. But the bridge clinic, one of them's at the Thurman Adams Center. It is in Georgetown. I apologize, that's a drive. But you can get mental health services regardless of payer status. And then there has been a change to the suicide hotline. You can call 988. So if you are experiencing a mental health crisis or having feelings about taking your own life or have reached really a breaking point, you can dial 988 and be connected to services. So I want to acknowledge again that, especially after 2 years of uncertainty and isolation, to then have to deal with this on top of it is a very heavy burden.
I'd also like to point out that declaring a public health emergency is usually used to suspend any and all rules that interfere with ramping up to the camera crisis. When we did with COVID, I mean, we just stepped around all kinds of laws to be able to create the infrastructure we needed to do. And what I'm hearing is that we're not at that stage yet. They can still do what they need to do right now without the public health emergency. People on this side of the table, what everybody knows about the emergency and brings awareness and everything like that. We can do that in other ways too. But the purpose of a public declaration is for state emergencies. It's for the governor to relax. We have a law that basically says when you declare the government declares a state emergency, you can set aside any law out there, and we can create temporary laws in the meantime. And we did quite a few of that during COVID. But that's part of the reason why it hasn't been done. Thank you.
I'm Mike DeFlavia. I'm actually a board member of Camp Rehoboth. I understand Delaware can't do it alone, right? You rely on community organizations and the federal government. What are you doing to coordinate with our federal representatives, Representative Lisa from Rochester, Senator Coons, and Senator Carver, to help get more resources to Delaware?
Sure, that's what I was just going to say. So the question is, what specifically are we doing to ensure that our federal delegation understands what's going on and the limits to our response? So we actively have conversations with them very frequently, especially during times like August, where they're in Delaware and out and about. We also work very closely with their staff members. Have also had conversations with Lisa Goodman, who many of you all know, due to her work with Equality Delaware, obviously Mark Rivera as well. I'm going to touch on it, but I acknowledge that he is part of Equality Delaware, to really ensure that advocates understand as well. I mean, I hate to say you all do such a wonderful job, and I don't want to say it's all on you to advocate on your behalf. I appreciate that that's an unfair burden, but again, I think all of our voices collectively pushing the federal government and HHS, CDC, FDA to do things like FDA did to really increase vaccine supply. There has been a ton of advocacy around the antivirals. It was developed really through military use to look at smallpox and to prepare the country if there was ever a smallpox outbreak. And so when this initially rolled out, there was forms and red tape. There's still a lot of that, but the way that it has become better and that we're actually able to start receiving doses from a federal stockpile of ChrisitanaCare has a pathway is because of advocacy. So we will join you in raising our voices and really making sure, again, that the delegation understands the specific concerns we have. And again, using regular briefings and opportunities as we have emergent situations to say, hey, I'm absolutely going to tell them that we have 200 vaccination spots at Camp Rehoboth that literally filled up in 5 hours. If that's not emblematic of the incredible desire to, again, protect people individually and as a community, I don't know what else is.
As a follow-up to that, is there anything we can do as community members to help you with advocating for this as well? Is bringing to our members of Congress something that will be additional voices that will help to raise the importance of this issue?
I think so, and again, this is an incredibly powerful group of people that probably have way better connections than I do, so please use them, and we will do the same. And it's not, I want to be clear, it's not the federal delegation obviously blocking anything. It is this really resource-constrained environment where there's just not nearly enough doses. But again, where there is red tape, where there is bureaucracy, that is where we need advocacy to really say, again, we're in a crisis. And if you look at, again, the community that is most impacted, that community is in crisis. And the one thing that, again, Dr. Drees can speak to way better than I can, infectious diseases don't exist in a bubble forever. And so we really need people to understand, while maybe the general public is not at immediate risk in the same way, we all need to care, and we all need to be focused on this issue and what we can do, because if we ignore it or other it and say, well, that's not my community, it will continue to spiral out of control, and it will then be in the broader community. So I hate to put it in selfish terms like that, but I think people need to understand that, again, we cannot other infectious diseases. A lot of this, again, Dr. Drees better than I can, but I mean, is linked back to an outbreak that started in Nigeria in 2017 that has now spilled across the globe and is causing, contributing and causing the current crisis we see. So again, whether it's COVID or monkeypox or another infectious disease, if we only focus on our own individual risk and then write it off if it's not there, it's at our own peril.
If I may just follow up with another comment, since you're having conversations with our federal delegation. Sorry to ask this of you to be the conduit of this, but as someone who is a new resident in Delaware after living in DC for 21 years, I'm excited to have representation. However, very disheartened that the lack of response to my reach out to all three of the representatives at the federal level, to implore upon them in your conversations to educate their staff and be responsive and meet their constituents where their constituents are meeting them, whether it's Twitter, Facebook, a phone call, or email. Thank you.
Happy to. The comment was, please implore the federal delegation to be responsive to people, even if it comes in through perhaps, I think now Twitter is pretty traditional, but I can appreciate, again, if it's outreach is occurring through social media, if outreach is occurring in communities, if the comment was it's incumbent upon elected leaders to meet communities where they're offering that.
So Amber, if you're going to say something, can you come forward so you can be more heard?
Oh, sure. So I have two questions. My first question is, if someone has sores and they have the breakout, do they have to isolate for 4 weeks by themselves, or can they cover the infected area and then still like go out in public? Like, is it something that he covers with like a gauze or a Tegaderm, or how would that work?
Yeah, so the question is, if someone does have lesions, do they really need to stay at home, all by themselves, or can they go out if the lesions are covered? I mean, I think that, it all depends on where the lesions are, right? So if they are coverable by clothing, I think the risk is lower. The recommendation, though, is to isolate at home and not leave the house except for, emergency or to seek medical care. And even if you have others living in the home with you, to try to isolate from other people, use a separate bathroom, use a separate bedroom if at all possible, just to minimize any chance of exposing others. We don't know, we know that the skin-to-skin contact is the primary route of how this disease is contagious, but there is also that respiratory route. It's not like COVID, where it seems like you can be across the room and still get COVID these days. But there is that risk as well. So I think that's one reason why we want to.
Okay. And my other question was, there's been talk that it can also be spread through like bedding, through linens. So my question basically is, how are we notifying hospital workers that work in like laundry services, hotel workers that are stripping beds? I mean, someone could be staying in a hotel and they don't know that they have it, and I'm just thinking like years of CNA work, that you're lifting those bags and chances are they're lifting them with their bare skin, they're, tossing them bags. So are we making the general public, especially in the hospitality service, aware that this could be happening?
Yeah. So the question is around bedding and other, and I think in hospitals, there is, if you have a known or suspected monkeypox case, we do handle the laundry similar to how we would handle other laundry. You don't want to shake it out or, really disturb it too much, but it can go through regular laundry. But of course, in healthcare, we're often wearing gloves, which is not true for hospitality service. So yes, I think there is that theoretical risk that someone who either knows or doesn't know they have monkeypox is in a hotel exposes that. I don't think that's the primary route of infection. I think the bedding would have to be pretty heavily contaminated, but there is that theoretical risk.
Do you think there's a risk that people have mistaken for more of a shingles virus versus a monkeypox virus?
Yeah, so the question is, could you mistake it for shingles? Absolutely. That's one of the diseases that we want people to be aware of. They can look a little bit similar. And if people, when we test for monkeypox, we often recommend testing for herpes and shingles and gonorrhea and syphilis and all the other things it could be, because people often have more than one infection as well. So yes, I think it could be.
Okay, and I have one last question. I'm sorry. What is the time frame that it lives on surfaces? Like if someone has a sore and it's on their hand and they hand you money, but they don't even know, like they're like, oh, that's just herpes, I have herpes, and what if it's not herpes? So how long can it live?
Yeah, so the question is, how long can it live on surfaces? And I have to be honest, I don't know that I've seen that as terms of like a certain number of hours. I think, again, they're not really talking about kind of casual contact, like handing someone money. It's really like clothing that you wear over your lesions or the bed that you're sleeping in. That sort of heavy contamination, I think, is what the risk is.
Okay, thank you.
I will say that I read the latest transcript from the White House's briefing on monkeypox from the CDC. And what they said there was basically an individual would have to rub the clothing that was touching someone's infected wound like this on their skin for a prolonged period of time for the transmission to occur. They said that is the non-sexual contact, and actually I wrote it down, is very low from what they know today. And so casual contact with bedding, but if it's prolonged or sleeping in bed, that probably is different than just taking the sheets off, what I understand. But I'll thank you for the question.
just really quickly, so there's, under the Division of Public Health, there's a unit that really works with employers and companies, and we have had calls with the hospitality industry to ensure that they understand what they need to do, because unlike, again, our health system partners that are very used to dealing with infectious diseases and have in-house experts like Dr. Drees, we appreciate that the average hospitality business owner is not going to understand or maybe even know where to look. So we have done outreach calls, and as Dr. Drees said, the good news is, similar to COVID, there's not some sort of decon, get the hazmat suit out. It really is, warm water and regular laundry detergent that you can launder linens, and if again someone's infected, I don't know if I shouldn't say that, but yes, we have provided guidance. It is available on our website. Additionally, too, also thinking about cleaning, really if there's, shared sex toys, fetish, anything that people are using, we really need people, even if it's not our primary route of transmission, to clean those things, just to, again, limit the risk of exposure if someone tests positive. And additionally, like we saw with COVID, where you form bubbles or pods of people, and really destigmatizing or acknowledging that this is more widespread. So there's nothing shameful about this behavior that people are engaging in, dancing, intimate contact. That's life. That's the things we do to be joyful and be human. So there's nothing shameful about it, and being open about it, and being willing to ask people about, what they've done, where they've been, not in a spirit of judging, but just really safety. Again, like we saw with people, if you're getting together, we were getting together for COVID, we're like, were you in a restaurant within the last, 5 days, have you tested? I think we really need to bring that kind of openness and destigmatize this as well, so people feel comfortable and know that they're not being judged or that they're not doing anything bad, and that's where they got monkeypox. It's just absurd language that we need to leave in the past.
Hi, Sharon Morgan. Ms. Amber actually asked some of the clinical questions that I had, but Doctor, if you could just elaborate, because there's two things that you mentioned. Number one, that unlike previous outbreaks, we've seen not so much the prodromal state, but straight scouting, and then the fact that it's being transmitted human to human in longer periods than we have had in previous outbreaks. Do we think that we're looking at something new or a variant to what has been previously? And then, Secretary, I do have a question for you.
Yes, that's a good question. So if I can summarize it correctly, I think the question is, are we seeing something new with monkeypox because of the way that we're seeing it behave differently and transmit differently? So I think they have classified the current outbreak strain as a different clade. So there are traditionally two different clades, a Congo clade and a West African clade. One is more severe than the other. When we first kind of started seeing cases outside of Africa, it appeared to be the less severe West African clade, but I think it's now been classified as a third clade. And again, I don't think it's dramatically different than what's been seen before, but it does, like I said, it does appear to be behaving a little bit differently in terms of how it clinically presents, how it's transmitting. I mean, I think there's a lot more to be learned as we continue on.
Thank you. And Secretary, in either the national or state level, are there media toolboxes that we can pull off of for talking points, creating images, our own marketing?
Yes, so we do have some of that available on the de.gov monkeypox site, one-pagers and other information. We're always open to suggestions. We work, there's some government information system that did a lot of the graphics and the work around COVID, and we're really sorry, team, time to get moving on the next infectious disease. So we will keep adding to that. And again, if there's specific suggestions or instant download, or could you do the high resolution, or we would love a toolkit specific to whatever it may be, we're always happy to again have that conversation, because we know that again, people having the right tools and distributing it to individuals and groups that trust them is far more valuable than anything we can do on our Facebook page or Twitter account. We just don't have the same reach that community members do.
I have a question. If an individual is signing up to get the monkeypox vaccine, and they're also thinking about getting a shingles vaccine, is there any concern or recommendation about whether or not you should wait if you're getting one versus the other? Is there any impact on that?
Right, so the Jynneos monkeypox vaccine can be given with other vaccines. You know, you always want to be aware of what's potential side effects each vaccine you potentially getting could have, because if you, and I haven't heard, you know, that there are significant side effects with Jynneos. The intradermal will be itchier, I should say, than the subcutaneous, and that itchiness might last for a couple of weeks. The shingles vaccine is kind of known as an allergy vaccine. So I mean, you just have to be prepared for potentially having twice as many side effects, or side effects from both. But you can give them together. The older smallpox vaccine, ACAM 2000, you cannot give with other vaccines.
Thank you.
I'm Patty from the Cancer Board member. If I understand correctly, there is a supply chain issue with the vaccine right in production. And based on that, and knowing we want to be more preventative than reactive, correct, sort of, right? Because that's obviously we learned that we want to be there versus reactive. Yes. So, where are we with that situation with the manufacturer? Where are they with ramping up on the vaccine production? Is the first question. And then from there, what is the process upon which it will be granted to the states, regardless of the number of outbreaks? Because obviously we want a preventative situation, not a reactive situation.
So the question was, what is the status, and are there manufacturing delays with the vaccine? And then what can we do to move beyond cases as the determinant for how vaccine supply is distributed? So I will say we're hearing a lot of we are working on it, which I do believe, but it's very hard when, again, you have impacted communities that are desperate for relief and information to say we're working on it. So I apologize that is the answer, but we are hearing we're going to get more vaccine, around 1,000 doses. Originally 1,000 doses, which now is over 5,000 doses due to the FDA emergency use authorization. Beyond that, we're not really hearing what else we're able to do. And so, especially when you have an index case who typically then has 5 close contacts, we are still very mismatched between just even cases or people who have been exposed, let alone people who, again, to your point, want to get ahead of it and prevent harm and suffering, even if it doesn't include hospitalization and death. Obviously, we would love to prevent anybody from having to isolate or go through this illness. So it is something that we know there is a lot of attention and growing attention on, which is always good, that kind of pressure. But both in terms of the supply chain issues as well as CDC moving beyond using cases as the determinant, we are just not hearing when that is going to change, which is again why the advocacy is so important. And it being a summer capital of fun, what a wonderful opportunity we would have to not just vaccinate Delawareans if we could get more supply, but to really again get ahead of this and prevent spread and suffering in surrounding states where we know people go home to. So we think we could do a huge public service for the region if we could get more vaccine here.
I see 1, 2, 3, 4. So that's where my eyes are. I apologize if you had your hands up earlier. So I'll start there with us.
Hi, Leslie Ladgar, and the Vice President of Rehoboth.
Nice to see you.
Yes, so you know probably the name of where I'm coming from. We have any help from our insurers, from the Medicare community, right now I understand vaccines are free, but eventually if it becomes widespread, we'll have to harness our payer community as well. And I don't know if any outreach has been done on that, and if there's anything we can do to help. And also, on the flip side, if the payer community is providing roadblocks like we sort of did in COVID already.
Now the vaccine is free, what will we have? It's free. Are we having conversations with insurance companies and payers for a future scenario where it's unlikely that it will be provided free by the government and instead be something available, potentially available the way other vaccines are? And then are we getting any, if those conversations are happening, are we getting any pushback or any roadblocks being thrown up? I will say at this point we are not having that conversation with the payers yet because we are pushing and trying to do the math and figure out how we can stretch our vaccine supply. But it's a very important point, and it's absolutely something we can't wait until we get up to the edge like we did with the COVID testing and vaccines. So absolutely take your suggestion, and we will make sure that that's included as part of our response, that we are having those conversations if and when we get to that point. I would love to be at that point because it would mean that we have much more robust vaccine supply and we've made this a more commonplace vaccination than it is now. So I welcome that time.
I will help start that conversation.
Thank you.
Hi, I'm Travis Stevens. I'm a massage therapist and a nurse, and I'm just curious what kind of screening protocol or recommendations there are to slow down transmission in case this does become endemic.
So the question is, in the setting of massage therapy or other kind of hands-on work, what sort of screening should be done? And I think, we can start now asking people about, we've been screening here for COVID for 2.5 years, right? You have fever, cough, blah, blah, blah. I mean, it's a lot of the same, the program is similar, fever, headache, muscle aches. You probably don't want to get real close and personal to anyone that has those symptoms, whether it's monkeypox or not, because who knows what it is. But certainly any knee rash would be someone that I would defer, send them to their healthcare provider to be evaluated, and only if it's shown that they're tested and shown not to be monkeypox or anything else transmissible, would I be comfortable doing massage.
So just to clarify, just kind of going off of the same kind of screening that we do already with COVID, adding the presence of a rash.
Yeah, adding the presence of a rash to the COVID screening.
Hi, my name is Ryan Schultz. Wondering whether a decade-old smallpox vaccination has any protection left?
Yes. Yeah, so the question is, if you were vaccinated for smallpox way back when, does that provide any protection? And the easy answer is we don't really know. We stopped vaccinating for smallpox decades ago. So if it was 30, 40 years ago, yes, there may still be some protection, but I probably wouldn't rely on it now. I would still give the monkeypox vaccine. Interestingly, one of the reasons why we think the cases have increased in Africa over the last decade or so is because of the cessation of the smallpox vaccination program, that they just lost that immunity. They happen to also cover monkeypox.
Yeah, thank you, Russ. John Rainier, just a question, a point of clarification. When you said that you had filled the 200 vaccinations this afternoon and it was members, were they all members of Camp Rehoboth? Wouldn't you clarify membership if you could?
I will actually let Lisa Evans, our director, answer the question.
We actually put the notice out to 4,200 people who are simply part of our newsletter guidelines. They are not necessarily, we have 1,300 members, so it went out to 4,200 people who we have email addresses for here.
Because
and we also put out, it went out on Facebook, it's been in press releases, etc. So it's been pretty widespread, which we certainly wanted to do.
Okay, because I feel the frustration from the other folks that have just had doors slammed or emails unanswered or phone calls. And I had inquired here at Camp Rehoboth about 5 weeks ago, and I was told that I would be put on a list, and I never received any communication at all.
priority wait list to ensure that people, because it's likely that people who sign up are going to cancel, because you have to commit to both dates in order to receive the appointment. So you can talk with Amber, right there, or Lisa, and we'll make sure to do our best to help you.
And I apologize, this was actually very important information that I neglected to include at the front and trying to be, it's my attempt to be brief. So starting next week, beyond the clinics that are happening here at Camp Rehoboth, as well as AIDS Delaware, our Division of Public Health clinics will also be vaccinating. We believe we'll be able to do over 900 vaccinations a week. And so they are appointment only just because, again, given that COVID is still here, to have people congregating, and especially to have people congregating to potentially not get the vaccine, we just didn't feel like was appropriate to do for people. So the hotline where people call to schedule the appointment is 1-866-408-1899. And the people who are eligible would be in the following categories: gay, bisexual, or other men who have sex with men and have had multiple, and by multiple we mean more than one, or any anonymous sexual partners, transgender women or non-binary persons assigned male at birth who have sex with men, sex workers of any sexual orientation or gender, and staff of any sexual orientation or gender at establishments where sexual activity occurs. I will actually ask about massage parlors as well. Jill's got a thumbs up, so we'll make sure to clarify that beyond just, not just, but beyond, again, how we've defined it, where sexual activity occurs, bathhouses, saunas, clubs. So again, that's the expanded criteria that starts next week at our public health clinics. We'll continue to rely on and we'll have future clinics in with community partners, but we understand that we cannot put the burden solely on community partners to vaccinate an entire population, and there's a continued role not just for the state, but obviously health systems, providers across the state to step forward and be vaccinating.
Would you mind repeating that hotline?
Absolutely. So the number again is 1-866-408-1899. You can also try emailing. I'm always worried about email just because, again, it's easy, as you mentioned. It can get lost, especially in the deluge. I know talking to Camp Rehoboth, they've been absolutely inundated with emails. So I would caution, but I also know some people just don't like to talk to people on the phone anymore. I get that. So the email address is P as in Paul, H as in hotline, call @delaware.gov. So again, that's dphcall@delaware.gov.
And we will be putting all of this information on our website as well, and I would like to perhaps ask the staff if we can consider doing a follow-up email that to list this information as a follow-up to people so that we can turn out. If you're not on our email list, then that's something I encourage anybody who's not on our email list to please make sure that you contact us on our website and sign up so that we can ensure that you're getting the latest information. Some people don't realize they're not on the list, they may have dropped off the list. And so there is another question from Preferred. Can you discuss the supply of antiviral treatments in Delaware? Do we have a supply of these, or are these also the most available vaccine?
Yes. So as I mentioned previously, or for the question, so as I mentioned previously, this was because this was done through military purposes. There's a lot of bureaucracy, inappropriate bureaucracy, because when you're giving people something, you want to ensure that there's not, again, indications that someone could have a severe outcome from a treatment or a vaccine. So there's a lot that doctors and healthcare providers think about when deciding whether a patient's appropriate for vaccine. So because of the way this was developed, when this all, when this outbreak started, there was a lot of red tape. Again, due to advocacy, the federal government is alleviating some of the concerns. Doctors can begin treatment and submit paperwork later. But to date, we have about 5 courses of this antiviral. And so because of that, we are looking at people at risk for severe monkeypox, which can include children, I believe, under 8. So if we see a pediatric case of a child under 8, we would consider that person for the TPOX as well as but basically, if there's people that we really are worried about severe outcome, it is something the CDC has set up a hotline for doctors and other clinicians to call. So it's not something that, again, if the state of Delaware, as a division of public health, and DHSS only have 5, that doesn't mean that there's only 5 in the state. It just means that what the state has received directly is very low, and so really people are receiving it through their clinicians.
Yeah, I would just add that it was an onerous process to get it up and running, but I think now that they have to review some of the paperwork, they have made it a little bit easier for additional doctors to be able to prescribe it. So, but my understanding is that it's, there isn't a stockpile here in Delaware. Like, you have to order each individual course from the CDC, and they take it to the strategic national stockpile. So, but it's not only going to be we have the we have the ability very soon to order courses as well.
Thanks. This is partially a follow-up to Melissa's question and also to Mike's. Because monkeypox lesions, genital and anal lesions, potentially pose a big risk for transmission of HIV. I know at the moment we're sort of material limited the vaccines, the antibiotic treatments, but in terms of, and where I'm thinking here is the training and guidance that our statewide HIV testing counselors need. Can we get some clarification and perhaps around the issue of using Ryan White money for focusing on the transmission angle, but the guidelines and training that our HIV testing counselors have done to do this effectively as the link between monkeypox and HIV. That's a suggestion, not your question, because I think it involves, talking to CDC.
So just quickly, for those who might be not heard, the suggestion from one of the audience members was to see Ryan White CARE Act money, which is provided by the federal government for HIV related costs, might be able to be applied here because in the transmission of HIV, you also have to listen to transmission of monkeypox. So I think that's a great suggestion, and Amber?
I just want to make sure that everyone does understand and that I am clear on this. Everyone in Delaware that's getting the vaccine is getting intradermal.
So that's how we are training. So the clinics that will happen here at AIDS Delaware, at the public health clinics, we are training our workforce to do intradermal. Individual doctors have the prerogative to do it differently. My understanding, Dr. Drees can clarify, there wasn't a directive from CDC that said you must deliver it this way, but obviously we were stressing, having conversations with clinicians, health systems, medical society in Delaware, that this is how we stretch the dosage and how can we have conversations around training or if there are concerns around it to really get people comfortable with it, again, so we can really maximize the vaccine supply.
Right, I completely agree with that and understand that. I just want to make sure that everyone's aware that that's what we are truly offering when they come here, that there's no surprises. And my last question would just be, if someone's really complaining that it's itchy, because we will get those phone calls, can we just recommend like some hydrocortisone cream? Or is it better just to let it run its course and not touch it?
So to first talk about the intradermal versus subcutaneous, I think it's a balance of trying to get vaccine doses out there more quickly versus taking the time to have to train people to do it intradermally. Just because that's not how we normally give vaccines, so it will take some time. So, but Senator Magarik is right. Like, there's not, you can do either one. The only impediment is if we end up vaccinating anyone under 18, they should get this traditional subcutaneous, because that's not part of the EUA to allow for intradermal dosing. As far as treating any itchiness, I think you can go ahead and treat with topical steroid or, you know, anything just shouldn't affect the vaccine.
So for
Thank
point,
you.
you're done?
Yeah, that was it.
Point of clarification, I do know people that received subcutaneous injection up to this point. Is the process moving from a certain point forward that all vaccination distribution will be done intramurally and no longer subcutaneously? People who went to Georgetown to get their monkeypox received it subcutaneously, as far as I'm aware. So is this a switch for all delivery, or just for the 2 sites that are being done next week?
So I'll only speak for our sites that are being done in partnership with us, where there are public health, Division of Public Health nurses or volunteers. We are training people and we'll be deploying it intradermally, but you know, as Dr. Drees said, I don't want to risk messing up or repeating. The study indicates that there's not a difference in efficacy, so this shouldn't be a point of panic when people say, oh no, I got it the first dose this way and the second dose, you know, intradermally. What does this mean for me? We want to reassure people, and to the point about people knowing what they're getting, that if they're going to a Division of Public Health clinic starting next week, or the community partner-based vaccination clinics, we are training staff to do it intradermally.
Thank you.
Who did you say was still getting them subcutaneously because that was the treatment but I just couldn't hear what you said.
No, so the emergency use authorization for the intradermal is for 18 and up. So if we do end up having people under 18, they're supposed to still be the same.
If you're coming to the end here, are there any? Okay, we have one here.
Just a quick follow-up. Is the vaccine, are people under 18 eligible for the vaccine? Are there any age requirements for the eligibility for the vaccine?
No, so so that was part of the emergency use authorization was to allow for under 18, and there's no minimum age. So if there was a household member of a case with monkeypox or happened to even be a young child, they would be eligible for vaccination. Thank you.
Thank you. Is there anything that people should know about the vaccine? Is it a live virus? Can they get the virus from the vaccine? Are there side effects? Is there misinformation about the vaccine out there that would scare people from having it?
I'm sure there is misinformation. There always is. It is a non-replicating viral vaccine, so it is not considered a live vaccine. Therefore, that's why, unlike the H9000, which is a replicating viral vaccine, you can't give it to people who are immunocompromised. You can't give it to people with eczema. There is a risk, of transmitting it to someone in the household. And so we're not using that one. We're using the Genios, which is a non-live vaccine. It doesn't have any of those potential worries. So you get it regardless of being compromised. You get it if you're pregnant. Again, give it pediatrics. And I think the only specific contraindications are in and out to a prior dose or.
Okay, one last question. Okay.
So basically, brief contact, being in the industry, by shaking hands or rubbing someone who may not know they're infected and they are infected, how easily is that transmissible? And second question, how did the term monkeypox came to be, the word monkey?
So the first question is about casual contact. And so the idea is that no, it's shaking hands, being in the same room with somebody briefly, walking past them on the street. None of those are risk factors for monkeypox. It really is that really prolonged skin-to-skin contact or direct face-to-face. They even say more than just a few minutes of kissing or whatever. So I wouldn't worry about potential contact. The question is, where did the term monkeypox come from? So it was actually originally found in research monkeys, which is where the virus was first identified. But it's not felt to circulate in monkeys in the wild. It's probably various rodent reservoirs in the wild. And WHO actually just had to put out a statement for people
not to kill monkeys, because there was so much concern, probably misinformation. So there are apparently monkeys are being persecuted, because of their concern about the vaccine. But it doesn't, they can be infected like any other mammal, but they're not, reservoir.
So I found this incredibly helpful and very informative. You really provided a breadth of information that I think for me is to clarify a lot of information. I think there's still a lot of questions people have, which means the good process of this is that thanks to DHSS making this a priority, and thank you to the Secretary, Dr. Drees, for coming here and spending this time with us. This is part of the effort that we all need to be doing. This is our commitment to Camp Rehoboth to ensure that we are keeping our community safe, and we will continue to take information in from the community. We'll continue to report it to DHSS to ensure they're aware of anything that we're seeing and opportunities for other partnerships or other things to make sure that you are getting information from the ground. We will continue to be your partner in this, and we look forward to doing that. I want to thank everybody here for taking time to spending with us. I know that I'm getting things on my phone about people who are watching it at home, so we are having a lot of people. This has been recorded, so people can watch this, and it's nice to see that it's actually closed captioned, so people will be able to see this afterwards. I also, again, want to thank the amazing staff. I want the staff to stand up who are here. There are 1, 2, 3, 4, 5, and there's an additional staff person who's not here. This work is being done by a very small team of people. I also want to ask the board members who are here to please stand up as well, because without their support, we're also here. This is a team effort. We're committed to our community, and we also thank our elected officials because we can't do this without you. The city, any opportunity we have to help with the city.